Hello, and welcome to the Infectious Disease Podcast. I'm your host, Dania Reynolds. In this episode, we will hear a discussion of how to implement earlier hepatitis B treatment best practices by Dr. Mark Sulkowski, Professor of Medicine at the Johns Hopkins University School of Medicine, along with discussion from Dr. Tatyana Kushner, Associate Professor of Liver Diseases at the Icahn School of Medicine at Mount Sinai, Dr. Paul Kuo, Professor of Medicine from the Stanford University School of Medicine, and a patient advocate, Jacki. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started and hear Dr. Sulkowski tell us about how to expand hepatitis B treatment candidacy.
Well, let's look at the goals of therapy. Viremia with hepatitis B is a risk for liver disease, including hepatocellular carcinoma. So the primary goal of many therapeutic opportunities is to suppress hepatitis B viral load. And we have very effective treatments with first-line oral antivirals that can achieve this in patients with chronic hepatitis B. We would like to see the loss of viral proteins or antigens, including E antigen, if a person is in the antigen-positive state, which is a very valuable endpoint. We know that that changes the natural history. We also want to normalize the ALT. And if one looks over time, people with high ALT are more likely to develop progressive liver fibrosis than those with low ALT. And finally, a lot of attention on functional cure. That is where the human immune system is able to control the virus and lead to the loss of surface antigen. This is absolutely a major goal, particularly of novel therapies in clinical trials. This is something that does not occur as often as we'd like it to with current oral antivirals. But if we focus on keeping the liver healthy and preventing liver cancer, as new therapies emerge that we'll talk about, we can hopefully achieve at a higher rate with novel treatments. So I want to look at the idea or the notion of expanding guidelines. What would it mean to bring treatment into some of these different patient subgroups? I'm going to start with cirrhosis with low viral load. I won't touch on this much more, but we know that cirrhosis is a very potent risk of liver cancer. The American guidelines currently suggest treatment in people with viral loads that are low, but it is a conditional recommendation. I'll tell you that in my practice, I treat patients with cirrhosis and a low DNA level. To me, it's not a negotiable state. I won't talk about that anymore, but that's because the risk of liver cancer is very high in that group. You heard a lot of discussion about the gray zone or intermediate patients. And perhaps what I'll say to this is, when in doubt, when we don't have sufficient evidence from the clinical trials, I'll pose the question, is it better to treat in the absence of definitive knowledge, or is it better not to treat? And I'll remind you that we practice medicine, the principle of doing no harm. And as some of the studies we looked at suggest, by treating people in the gray zone, we're actually taking a more conservative approach. I'll come back to that. But I want to focus on this group that is E antigen positive chronic infection, the so-called immune tolerant patient. These are generally relatively young individuals with very high levels of virus who may have relatively normal ALT levels. There's a lot of debate right now about whether or not to approach treatment in this group. These patients are at risk for integration of viral DNA into the human genome, which may increase their risk of cancer. That's occurring while we watch their viral infection. We can also preserve their healthy livers. We know they have minimal fibrosis or scarring. If we follow these patients, we may lose them to our clinical care as their lives get busy. And when they come back, much may have changed, including progression of disease. This idea of treatment as transmission prevention. A lot of young people that I talk to about their infections were concerned about transmission to family members, to sexual partners, concerned about even in the workplace, whether their transmission can occur. And this last point about stigma, I think it's really important to understand how the person with hepatitis B lives with that virus. What does it mean to them, and how do they experience stigma in their work and family and community lives? There are, of course, some arguments against that. One is these patients may have high viral loads that are hard to suppress. They have minimal liver disease, so if we're treating an inflammatory condition, they don't have disease. And then there's this idea of committing to long-term therapy. And this is something that I talk to patients about. I think we do want to understand what the expectations are for treatment with respect to pill taking and how long to stay on therapy. But I think you'll find a lot of people are really open to discussions about treatment. I want to dig a little bit deeper into this idea of the virus as a carcinogen. This is a really fascinating study. There is one group of patients for whom universal treatment is recommended. People with HIV and hepatitis B, we recommend treatment for all patients, so universal therapy. And this looks at a cohort in North America, about 8,354 people with both infections, HIV, Hep B, and 115 cases of cancer. And they asked the question, did viral suppression, hepatitis B, influence the risk of cancer? People with HBV viral suppression were nearly 60% less likely to get cancer. And if the viral load were above 200, then the risk increased substantially. So in this population, viral suppression in the era of universal treatment reduced the risk of cancer over time. Now, we're eager to see these types of studies in monoinfected patients, but very provocative and compelling data. So what if we did expand the treatment criteria to treat more people? And there's a couple of different scenarios. In this population of patients, about 1.4 million in South Korea, if they eliminated any discussion of the guidelines about e-antigen status, so ignore e-antigen, ignore whether the ALT is high or low, and just look at viral load. So what is the predicted outcome if we just treated people with chronic hepatitis B and a viral load greater than 2,000? Well, more people went on treatment. That's to be predicted. In the current model, the base, if you will, there's a relatively small number of people on treatment, and that increases. But look what also increases: the benefit. The number of liver-related deaths declines, the incidence of decompensated liver disease and cancer also declines. So simply by treating this as a viral infection, we can certainly do better. If we look at the US population, now we get into cost effectiveness. And here's an analysis looking at disability adjusted life years and setting a cost of treatment at anywhere between $2,000 and $750. And what the models show is if we treat all people with chronic hepatitis B, is it actually becomes cost savings if the amount of cost of treatment annually is $750 or less. In other words, the society saves money. Well, I got onto GoodRx and saw that you can actually buy a year's worth of antiviral therapy for around $200 US. So meeting that criterion for cost savings for treating all. That's not to say cost is not important, but it's not as much of an impact as we might think. So given all the discussion we've had about hepatitis B as a risk for hepatocellular carcinoma, it's no surprise that a number of experts in this field have suggested we simplify the algorithm. There's confusion about what a normal ALT is. There's confusion about whether it should be 2 times upper limit normal. But in this guideline, the recommendations were relatively straightforward. Cirrhosis, treat everybody. If the viral load is greater than 2,000, independent of ALT, the recommendation was to treat. Now, if the ALT is high, they would treat at any viral load. But you're seeing this greater emphasis on viral load, with 2,000 as kind of the magic number for if the viral load's above that, we want to treat. Other experts, Doug Dietrich, my colleague in New York, incorporated age into this. And this takes into account one of the truisms in life, which is most diseases tend to increase in severity over time as we get older. And we know the liver cancer risk increases as one gets older. So if you're older than 30 and the viral load is greater than 2,000, treat at any ALT. This is very similar to some guidelines recently adopted in China, where they set any detectable virus level. Under 30, the ALT comes into play, and you'll note they're using relatively normal ALT and AST levels. So these are some expert-based guidelines that are being discussed. And on a global stage, where there are nearly 300 million people with chronic hepatitis B, the WHO is in the process of updating their 2015 guidelines. And one of the goals of the WHO activity is to really expand and simplify how we're approaching antiviral treatment for people with hepatitis B. So expanding treatment criteria, really looking at two groups of patients with a laser focus. One is the so-called immune tolerant patients. These are the hepatitis B e antigen positive, high viral load, chronic infection patients that we talked about. And then this gray zone population, I think, is something that we're definitely really beginning to focus on. So they're going to expand the guidelines. Now, I want to bring up another topic, which is the importance of bringing in people with chronic hepatitis B into the guidelines discussion. We talked about ALT levels, viral loads. Well, how does the patient view living with Hep B? We know there is fear of progression, there is concern about transmission and stigma, and there's concern about physical well-being and health. Really important to engage the patient in shared decision-making, and even to engage patients in guidelines. Rather than have a group of experts sitting around a table or now a Zoom room talking about which patient should be treated, we certainly will want to think about their perspective as we integrate what's valuable to patients, as we integrate things like transmission or stigma, and talk about how we translate these guidelines to actual clinical practice. So the need to include people with lived experience in guidelines. Now let's just talk briefly about the current treatments. Let's look at long-term treatments with entecavir to tenofovir. You can see here we're going to suppress virus levels, and we're going to look at high rates of viral suppression, and really most patients are treatment candidates. One of the things I've heard people talk about is the low rates of S antigen loss. Certainly in my practice, I've been practicing long enough, I do see S antigen loss, but I tell patients, we're going to keep your liver safe and healthy and reduce your cancer risk while we work on novel therapeutics. We are at a very exciting time in the development of antiviral and immunologic approaches to treat hepatitis B. There's a tremendous amount of science looking at the viral life cycle, how the virus enters the cell. We now have entry inhibitors like beloveritide that block the NTCP receptor. We're now looking in clinical trials at medications like small interfering RNAs and ASOs, antisense oligonucleotides, that can block the translation of viral RNA. Really very important. So while this is going to take some time, I tell my patients, let's keep your liver healthy while the science moves forward. So the take-home points. There is a huge effort underway to expand HBV treatment. Focus on lowering the risk of long-term complications and focus on the virus. This 2,000 threshold is gaining traction as a metric in which to decide whether someone needs treatment, shifting to a viral disease, not an inflammatory disease. We do want better evidence, but our patients and people with hepatitis B can't afford to wait for these trials to be funded and conducted, because that may never happen. I'm going to turn it over to Tatyana to lead us through some discussion.
To hone in on one of the initial points that you made, that you do not use the term lifelong for patients, but at least some of the patients that I see are quite really want the details. So if not lifelong, then for how long, and what could be the other endpoints that we're looking for. So how much do you share about this idea of functional cure and other endpoints that you may be targeting?
So I always, with patients, share my excitement and enthusiasm for the scientific advances and the clinical trials being conducted in hepatitis B. They may not want to participate in a clinical trial, but I want them to know that the world is pushing forward with novel therapies to target the virus and the immune system, with some medications, one in particular, entering phase 3, which could be here in 2 to 3 years. So I want them to hear my enthusiasm for higher rates of functional cure within a 5-year period, And then if I expand that to 10 years, I think we're going to have many more options, particularly as we advance the science of cell engineering.
Great. So you give them that 5 to 10 year horizon, and really that sort of becomes kind of a surrogate endpoint potentially for patients in terms of their treatment plans. Great, thanks. And then Jacki, so I know we really highlighted here the importance of joint decision-making, shared decision-making, but to what degree do you really want your doctor to tell you, well, this is what you need? And to what degree does opening this can of worms actually make this more complicated to say, well, now I have to make the decision. Aren't you the doctor who should be telling me what to do?
Exactly. I'm also an advocate. So we have a patient group, and we have a very hard time to convince our patient not to listen to their doctor. They have to listen to their doctor, obviously. And that's very important. That's why the guideline is so important, that the patient would listen to their doctor, not to us. So it's very important that you have a consensus so we can advocate. Otherwise, we will be in direct conflict with the doctor's recommendation. Now, there's one point that I want to raise, if it's okay, for just one simple question on the proposed algorithm. I really like the simplified algorithm, and the thing that I like particularly is to treat everyone with cirrhosis. You have that for a long time, although it has been challenged recently, but to treat everyone with cirrhosis is one great idea. And taking that idea, however, what is missing is that you have to consider, if I'm in F3, if I'm in F2, now you should treat us as well. The fibrosis is progressing, the liver, the virus is doing the damage to the liver. You cannot, if you would change that cirrhosis into F2, treat everyone that has liver fibrosis, it's been damaged by the virus, then you should treat them, get rid of the virus at any viral level without, because the viral level would change, right? So at any viral level, if you have F2, then treat them, or at older age, like the second proposal with age above 30, for example.
That's true. And even our more conservative guidelines, really do highlight that if you have F2 fibrosis or higher, you really should have a lower threshold for treatment. So very much, I agree with that. I wanted to get to the audience Q&A. So Mark from the audience asked, could you speak to the risk of forward transmission in patients who do not meet DNA thresholds per guidelines, but are still viremic? Really the question of transmission of the virus. So Paul, can you speak to that in terms of the risk of transmission in those who do not meet DNA thresholds?
Well, certainly there's a gradient, Tatyana, in these individuals. And, it depends on how transmission occurs. So, we typically see e-antigen positive young people. Actually, that's the group I worry the most about. These are individuals running around with hundreds of millions of virions, and they're in college, they're sexually active. These are the highest risk. There is still a transmission risk in these individuals, I think, with lower HBV DNA levels, but I think there's going to be a gradient risk as you fall in your viral level.
Right. So definitely highlighting that those, again, immune tolerant patients that do not meet guideline criteria, yes, those are for sure at very high risk of transmission. And of course, yes, lower viral loads have lower risk, but still have an existing risk of transmission that we should be aware of and be counseling our patients about. And then Eliza from the audience asked the following very important question. So she said that one barrier I run into often is poor coverage of hepatitis B medication options and limited cost assistance options. Our clinic has started to offer treatment to patients in the gray zone, but the cost has at times led patients to decline treatment, especially when they are in gray zone. This begs the question, how can we as healthcare providers advocate for better insurance coverage of medication? And how do you recommend approaching this with patients who may have high copays? And Mark, I think you alluded to it earlier, but maybe you can expand on that.
Yeah, I'll make a couple comments. And I'll just to comment on the last question, I will say that treatment as prevention is a cornerstone of hepatitis C and HIV treatment, and really does need to be a topic that we talk about in Hep B. In terms of how do we get access to treatment, absolutely we need to advocate for the voice of people with hepatitis B to be heard and treatments to be covered. No question about that. Advocacy is something that we need, and we need to speak up louder and louder. But I have become a huge fan of GoodRx. And what I found just before I got on the call is that for $190 for an entire year, we could obtain a generic antiviral treatment. Now, fortunately, in our clinic, we have had the ability through philanthropy to raise some funds to cover patient out-of-pocket expenses. But this is an important area, but just highlights that we're not asking third-party payers, insurance, to pay for a lot. This is not going to break the bank of Medicaid, for example. So I do think we need to speak up, particularly as more patients get screened and come to our practices.
Great, thank you. And I think that, for sure, cost can become an issue, but hopefully as we really recognize the importance of, begin to recognize more the importance of treatment and really the huge benefits on disease outcomes, that insurance companies will also come on board and recognize that as well.
I'd like to thank Dr. Sulkowski, Kushner, Kuo, and Jacki for that excellent discussion, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on Are We Early Enough?, key questions, and the timely management of HBV and HDV, on our website, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.